Can you keep your existing health insurance under the Affordable Care Act? Where's the best place to shop for health insurance now? And how can you determine if you'll qualify for a subsidy? We'll answer these questions and more on this, the fourth episode of the DoughRoller Podcast.
Welcome to the DoughRoller Podcast, where the best thing money can buy is financial freedom. We help you make more, spend less, and invest the rest. And now your host, Rob Berger.
Hey everybody, whether you're just starting out, buried under a mountain of debt, or well on your way to financial freedom, this is the podcast to help you take your finances to the next level. We've got a very important show today. I have an opportunity to interview Nate Purpura. Hope I've got his name right. Nate works at eHealth, which is an online, it's a website where you can shop for and buy health insurance. And the folks at eHealth are probably as well informed about the Affordable Care Act as anyone. And Nate was kind enough to come onto the show. And actually, we have a fairly lengthy interview where we go through all of the details of the new health law to answer those questions that I think are nagging all of us, particularly those who are in the market for individual health insurance. And so I'm going to turn over to the interview here very quickly. I got an email, though, from one person that I want to share with you. I often refer to the healthcare law as Obamacare. And a reader emailed me with a comment and said, well, since you refer to it as Obamacare, we know how you stand on this act. I guess he meant that calling it Obamacare is a bad thing. I'm not exactly sure because in the press, it seems that just about everyone refers to it as Obamacare. The actual name of the statute is a bit of a mouthful. It's the Patient Protection and Affordable Care Act, which is a rather lengthy way to describe it. So I tend to just call it Obamacare. But I want to kind of say two things about this reader's comment. First is, like probably just about everyone, I have strong opinions about the new health law. There are many things about it I don't like. I do think it helps some, as most large programs like this do. But I also think it hurts a lot of people. And it really depends who you are and what your situation is as to whether you like this new law or not. If you are someone with pre-existing condition who couldn't get health insurance in the past or couldn't get health insurance at an affordable price, I suspect you very much like the new law. I would too if I were in that situation. I also think if you perhaps don't have the income to be able to afford health insurance, you probably very much like the subsidies that the healthcare law offers, and I would as well. You know, on the flip side, it's going to raise the cost of health insurance for a lot of people. I have a good friend. He owns his own business. He's in his 50s, and he buys his own health insurance. And he was kind of laughing about this, but he said, you know, Rob, I've got to now buy health insurance that includes maternity care. He looked at me, he goes, I'm pretty certain I'm never going to get pregnant. He's got to buy health insurance that includes coverage for mental health. He's got to buy insurance that includes care for children. And, you know, he just obviously he doesn't need it. And the result is his rates are going to go up significantly. So, you know, I think with any large entitlement program like this, there's going to be winners and losers. And I think there are a lot of winners and I think there are a lot of losers. And so I see some good things that the act does, but I kind of see a lot of the bad things it does as well. That's sort of point one. But the more important point for today is this. The interview today is not about the politics of Obamacare or the Patient Protection and Affordable Care Act, if you prefer. My goal in bringing Nate on the show was to just answer questions about how the healthcare law works, whether you like it or not. The idea was to provide you all with some basic information, particularly for those that will be shopping for insurance under the new exchanges, so that you can find the best insurance at the best price for your specific situation. So in this interview with Nate, we avoid the politics and we focus on the nuts and bolts of Obamacare. So with that, let's turn to the interview. Hey, Nate, welcome to the show.
Hey, Rob, how are you?
I'm doing fine. I appreciate your time today. I know with all of the things going on with the Affordable Care Act, you've been extremely busy, and I appreciate you taking some time out of your day to help
absolutely,
us.
yeah.
Okay. So as I mentioned before earlier in the show, you work at eHealth, and I know I kind of refer to eHealth as a private exchange. That may be the wrong way to think of it, but can you kind of just give us a little bit of your background, what you do there, and what the company does?
Sure. So eHealth is a online marketplace for health insurance. So, we're kind of like the Amazon.com of health insurance. We've been in business for 15 years. We're licensed to sell health insurance in all 50 states and the District of Columbia. We have over 10,000 health insurance plans on our website from about 200 insurers nationwide. So we're the biggest online marketplace for health insurance in the country. This is major medical insurance. We also sell things like dental, vision, life insurance, so various products. But our primary business is individual and family health insurance plans, small group, and we also sell Medicare Advantage, Medicare Supplement, and Medicare Part D. So we're sort of a cradle to grave marketplace for health insurance products. And my role here is as director of communications. So I run things like public relations, and we do a lot of customer communications, things on our blog, email newsletters to go to customers and things like that.
Okay, great. Well, I kind of want to jump right into it. As I mentioned to you, you and I just spoke for a couple of seconds before we started the interview. I've got a page and a half single-spaced questions and topics. A lot of them come from readers of my blog or subscribers to my newsletter, and so I kind of want to just jump in if that's okay with you, and because I think there's a lot of unknowns and uncertainties, and folks have some questions when it comes to the Affordable Care Act. And I thought where we'd start is this whole sort of recent development about whether or not folks can keep their old insurance policies if those policies don't meet the new standards under the Affordable Care Act or under Obamacare. Can you kind of shed some light on that for us?
Yeah, so this is not really a new development, at least for us. We've been aware that people are going to have to be transitioned to new plans for really since 2010, and in the last year we've been working on sort of a comprehensive communication plan to try and move customers into a compliant plan for next year. Now, in some states with some insurance companies and with some insurance plans, insurers were allowing customers to renew their plan early or renew it before the end of 2013 and then keep it another year. And that's still an option for some people in some states with some insurance companies. So it's a little bit all over the place. So we've had to have a really detailed, insurer by insurer communication plan to sort of communicate this effectively for everybody. The decision made by the president last week shook things up a little bit for some insurers in some states. And in some other places, not so much, because, again, this was already sort of being allowed. So what I've gotten from our agent team, I have a list I'm looking at right now that says Maine, Kentucky, Ohio, Iowa, Wisconsin, Florida, North Carolina, Kansas, Texas, Arizona, and Hawaii, Oregon, and Maryland will allow renewals next year. Now it's unofficial, but this is what they've been tracking.
And that would mean folks could keep their old insurance at least for a year in those states, even if the insurance doesn't meet the new standards.
Yeah, that means that the state apparently is decided to allow that. And so the state's insurance commissioner has to make a decision on whether or not they're going to allow that. In some instances, the state's exchange may also have to let insurance companies out of their contract, that kind of thing, or change the contract. So this is states where the state's insurance commissioners come out and said they will allow it, and then it's up to the insurance companies as to whether or not they can pull it off. So again, that's Maine, Kentucky, Ohio, Iowa, Wisconsin, Florida, North Carolina, Kansas, Texas, Arizona, Hawaii, Oregon, and Maryland. That's an unofficial list. And then states that so far we believe will not allow renewals, they've made some sort of public statement: Massachusetts, New York, Rhode Island, Vermont, Georgia, Washington, Minnesota, and California. And then the rest, it looks like they're still sort of up in the air. There hasn't been an official statement made.
Okay, and let me just say real quick for those listening, I will repeat all of those states in the show notes. So if you missed whether your state fell into those lists that Nate just gave us, they'll be at DoughRoller.net/podcast4, which is where you'll find the show notes. So Nate, I mean, it sounds like a lot of this is just going to come down to where you live. Either you live in a state that allows you to keep your insurance or you don't.
Yeah, and it may also come down to your insurance company. Either your insurance company is able to pivot really quickly and reissue those plans and re-enroll you, or they decide logistically it's just not something that they're capable of doing, or it doesn't work with their risk profile. So, there are a lot of moving parts here. It's unfortunately not as simple as just, saying, all right, we're gonna turn this around for 12 months. So
even if you live in a state where the insurance commissioner has said, yes, we'll allow you to keep your policy for another year, the insurance company that you had may or may not be able to actually do that, or be willing to do that.
Correct. And in fact, in California, for example, the state insurance commissioner came out and said, we would allow this, but Covered California, which is the state's exchange, has to change the contracts they have with the insurance companies, because the exchange, every insurer that's offering a plan on the exchange had to sign a contract saying we will move all of our customers from their old plans to new plans on the exchange. And so while the state's insurance commissioner said that they would allow people to keep their old plans, it would require the exchange to let insurers out of those contracts or to change the contract, and the exchange decided not to do that. So just to show you, this is really complex. It's different in all 50 states, and there's a lot of layers of complexity here. So, what we've been telling people is just pay attention to your mail. You get any sort of mail from your insurance company, open it up and read it. Pick up the phone and call if you don't understand it. If you're an eHealth customer, we obviously encourage you to give us a call. We can help you walk through it, but it's just going to take a while for some of this stuff to shake out. So it's sort of a moving target at this point.
Okay, and I kind of want to dive into this just in a little more detail so folks understand what's going on, and tell me if I may have this wrong. But first of all, under Obamacare, there are what I think the statute refers to as essential benefits that
Correct.
Right. Okay. Every health insurance policy, regardless of who buys it, has to meet these new standards. Is that right? That's correct. Yeah. Okay. And so, and by the way, I'll leave a link to folks in the show notes to where they can go find those standards. I mean, but sometimes those standards kind of result in odd things. For example, I've got a good friend who owns his own business. He has his own individual policy, and he was telling me that under the Affordable Care Act, he now has to have coverage for maternity, even though he's pretty confident he'll never get pregnant. Is that right, or is he just mistaken?
No, in fact, we did an ebook on this, and so I can give you a link to that after your show. But there are 10 benefits that every plan has to cover. It's laboratory services, emergency services, prescription drugs, mental health and substance abuse disorder services, maternity and newborn care, pediatric services, including oral and vision care, rehabilitative and habilitative services and devices, ambulatory patient care, preventive and wellness services and chronic disease management services, and hospitalization. So that's 10. It's a long list, and the book kind of gives you a little bit more detail on those things. But so you're right. Particularly in the individual market, you used to have much more sort of an a la carte menu. So you could say, I'm a 50-year-old man. My wife is 48, or I'm not married, or whatever. I don't need maternity benefits. I'm not going to get that. What we used to see, what we saw in the old market, we do a report every year and we look at benefits that are covered by plans. We saw that of the 10 essential health benefits, and these 10 are new, so we didn't quite have an apples to apples. We sort of grouped them differently, but the benefits that were most often not covered in the pre-ACA plans, or I shouldn't say not covered, but not purchased by customers. Maternity and newborn care was a big one, so only about 25% of people bought a plan with maternity care. Pediatric dental was not something that was typically offered or purchased, and certainly wasn't something that we tracked, so it's hard to get a read on that. And then the mental health services were typically not either offered or not purchased by people. So everything else, there seemed to be pretty good crossover. There was in the 80 to 90% of plans covered those kind of benefits, covered prescription drugs. or at least I shouldn't say 80, 90% of plans covered those things. When people went into our marketplace and shopped for plans, the plans that they decided to buy covered the majority of the services that I just ran through. The ones they decided to buy, sometimes, 75% of the time did not offer maternity or newborn care, typically didn't offer mental health, and didn't offer pediatric dental. And I should say, too, that in some instances, those benefits were not always available. For instance, I know that in Texas, for some people, it was difficult to find plans with maternity at times. You might have to buy it with a rider or things like that. So it was really kind of a very diverse marketplace of products, I guess you would say. There was a lot of variety. And so they try to create some standardization here, make it a little bit easier for people to understand what's covered and what's not covered. And then there's a bit of risk sharing here too, right? I mean, men typically paid less for health insurance in the individual market in the past than women did, oftentimes because they were buying plans that didn't offer maternity coverage, and maternity coverage is more expensive. So one of the things the law tries to do is sort of share risk more evenly. And so if I think the idea here is that if everybody's buying plans with the same coverage, then even if you don't use it, you're making it cost less for somebody else who will use it.
Okay. And that's sort of the policy argument, and I suppose different people could disagree, but the idea is, we're going to kind of force everyone to buy the same plan, even if it includes coverage you won't use, or in some cases, I guess, couldn't even in any set of circumstances use, but it'll sort of spread the risk and the costs out to everybody.
Right, that's the idea. So
okay.
Yeah, you can argue whether or not that's a good idea, and people certainly have. But that was the idea: is that we're going to share the risk. We're going to create one big risk pool, as opposed to 300 million or 100 million or 15 million individual risk pools.
Okay, so one of the reasons that folks were seeing their policies canceled was because the policies they had didn't cover those 10 essential benefits you described for us.
Yes.
Okay.
Yes.
Now, there's also this, I guess they call them plan metals, I think, but there's, platinum, gold, silver, and bronze. Can you kind of explain how that works and what those mean?
Yeah. So the law says that every plan has to cover a minimum actuarial value of 60%. And what that really means is, it has to cover 60% of your costs or higher up to your plan's out-of-pocket maximum. So, so there's 4 tiers. There's a bronze tier, a silver tier, a gold tier, and a platinum tier. The bronze tier is the lowest, that's 60%, and it grows in 10% increments until you get up to platinum, which is 90%. And so obviously the bronze plans are less expensive, and the platinum plans are more expensive. And then the out-of-pocket maximums for these plans, if you're an individual, it's $6,350. So a bronze plan would cover 60% of your costs up to that threshold. And if for a family, it's $12,700, and the plan would cover 60% of your costs up to that threshold. And it can do that in a number of ways, right? It could do that with one big whopping deductible, or it can do that with a certain size deductible and co-insurance, which is where the insurance company pays a percentage and you pay a percentage. So that's where you see some of the variety and differentiation in the plan.
Oh, okay. And just breaking that down a bit. So I take it before Obamacare, there were plans that people could buy that didn't promise to cover up to 60% of your health insurance costs. They covered less than that.
Yeah, up to a plan's out-of-pocket maximum, yes.
Yeah. And I take it those plans, too, might cause you to lose your previous insurance if they didn't meet that 60% threshold.
Correct.
Okay.
Yes.
So, and I want to dive into the caps that you mentioned and a little bit more on the metal plans, but just to kind of close out the issue of folks that may have had their insurance canceled, and they have a choice to make, right? If they have the option of keeping their old insurance, and as you've said, not everyone will, but if they do, they've got that option versus buying a new policy under the new law. How do they go about? Do you have any sort of words of wisdom about how they go about making that choice, and when should they make it? Because everything seems to be in flux. You've got the mandate where you get penalized if you don't have insurance. Plus, folks, I think, just want to have coverage, and they've got this choice now. They've got to kind of wait to see if they can keep their old insurance or not, and then they've got to make that decision. Do you have any sense as to the timing or how long they'll have to make that decision, and when that decision can be made?
Well, so again, in a lot of instances, people have been given an option and given an alternative. But if you have not, or if you're still waiting to hear if you can go back to your old plan, the deadline to enroll in a plan that has an effective coverage date of January 1st, so the last date nationally that you can do that is December 15th. Under the law. So now some states have extended that to December 23rd. I believe California did that, but I would check. So you've got, really 3 weeks, I guess, if you really need coverage starting January 1st, you've got about 3 weeks to make that decision. And, I would assume that most insurance companies are going to make a decision here, by today or sometime next week. It's complicated more by the fact that we're getting into Thanksgiving. But there's a lot of moving parts here, so it's a challenge. And I would just say again, pay attention to your mail. Maybe reach out to your insurance company. But the thing that I would encourage you to do is go to an exchange, either a government exchange or a private exchange like us, and shop around and look at what's available. We will have the ability at some point to enroll people in plans with a subsidy at eHealth, but we're still working on that functionality with the government. The problems with healthcare.gov have sort of delayed that. I know that they are improving healthcare.gov, and if you live out of state, if you live in a state that's using its own exchange, the exchange may be working fairly well if you qualify for a subsidy. In some states, it's not working at all, and then you have to call and sort of do it offline. So it's a really mixed bag. But I would just say don't wait till the last minute. Pick up the phone. You could start with eHealth. We're a pretty good resource. We're in all 50 states, so our agents have a pretty good grasp on what's going on in your state. Probably know what your insurance company is or is not offering. I think that's a really good place to start. I don't know if the exchanges would have people that really know that kind of thing. I would assume they probably don't, because they hadn't sold the pre-ACA plans.
Right. Okay, and then I want to circle back to something you said about the caps on out-of-pocket costs. So for an individual, I think you said it's $6,350, and for a family, $12,700. So regardless, are those the caps regardless of whether someone buys a bronze, silver, gold, or platinum policy?
Yes.
Okay. And for an individual, for example, it's just for sake of an example, let's say they've bought the bronze plan and they end up spending $6,350, whether it's would that include literally everything they spend, for co-pays, deductibles, co-insurance, or co-payments? All of that adds up.
That's my understanding. Now, there may be certain details or caveats in the plan about medical devices, or that's sort of beyond my depth.
Sure.
That's definitely something I would talk to an agent about. I actually have a family friend whose 2-year-old has cancer, and they're losing their plan, and they're trying to find another plan for their child. And I spent quite a bit of time with the mother on the phone a couple days ago, just trying to sort of walk through what her concerns were. And I had to put her in touch with one of our agents, because she said there are things that her plan has an out-of-pocket maximum now, but then there's cost sharing for medical devices and things like that, and medical equipment that she has to buy. And she's obviously, even some of it's really expensive, so she's very concerned about will these new plans cover it? And that's something that you really need to be a licensed agent who's been appointed by an insurance company and has been through the training to know what a plan actually covers. That's, when you're in that area, you really need that level of detail. Well, and so I would encourage people to, if you're in that boat, you really gotta pay attention to those finer points.
That's got to be heartbreaking to be dealing with the child with cancer and then have to go through all of this in terms of finding new policies. Well, okay, whatever costs end up going into this cap, once an individual reaches that cap, they've paid $6,350 out of pocket if they're an individual. Does that mean that for the rest of the year, the insurance company pays for the rest?
Yes.
Okay. And then again, $12,700 for family coverage.
Yeah, and some plans may have lower out of pockets. That's the very end.
Okay, that's the maximum.
That's the maximum.
Okay.
Yeah.
Okay. Okay, and then you mentioned shopping around. You can look at either the healthcare.gov if you're in a state that's covered by that site versus individual state health exchanges. And as I've mentioned to my readers, I've got a clickable map that they can go to DoughRoller.net/Obamacare map. And they can click on their state. It'll take them to their health exchange. But I actually went on healthcare.gov, as you probably know, without inputting any personal information. You can now get what they call an estimate of your coverage. So I did that, and I picked Platinum plan for where I live, and they showed me two options. And then I did the exact same thing on eHealth, and I got the exact same two policies.
Yep.
So I got a couple of questions about that. First of all, Will all of the policies that are available in the exchanges also be available through companies like eHealth?
If the company is licensed and appointed as a what's called a web broker entity by the legislation, but if the web broker, the marketplace like eHealth is allowed to enroll people in subsidized health insurance plans, which we are, then once that feature is turned on and you go on and you shop with a subsidy, you will see everything that's available in that marketplace. By law, we have to show you plans, even plans that we can't sell you. So you have to know that there are options in your market, even if we're not, we can't sell it to you because we're not appointed. So that's the way that's the way the law envisioned it to work. Now, we are not set up with that yet. We're still working on the implementation. We really needed to start the implementation probably in July. We got the details and started working on it at the end of September. So we're still working on it, and then the delays with the government website have made getting that implementation challenging. But so we don't have everything available right now, but we will. But we do have a lot of the plans. We do have, and I'm confident we have the largest inventory of plans, of exchange plans outside of what's on the exchanges of any marketplace. So, in a lot of cases, you will find the exact same stuff there.
Okay, and
that you find on our site.
Okay, you referenced subsidies, but I'll circle back to that. But what about folks who know they need insurance, but they're not going to qualify for a subsidy? I take it they can buy insurance through eHealth now.
Yes.
All right. But if someone thinks they may qualify for a subsidy, eventually, once all of the kinks are worked out of healthcare.gov, they'll be able to buy those policies either through the government exchange website or through an exchange like eHealth, and I assume others, and still get their subsidy.
Correct.
When do you think that functionality will be working for the private exchanges like eHealth?
I cannot give you an estimate on that, unfortunately.
Are you guys basically waiting on the government for that?
Well, we're a public company, so everything that we don't launch things that don't work, and we have a pretty rigorous testing program here. So we are working with them on the implementation, and we're testing it, but we just don't want to put it live until we're really confident that we can get people through it. So that's a process that we're working through right now.
Maybe you guys should have built healthcare.gov.
Yeah, well, that's that's water under the bridge, I guess, right?
Yeah. As an aside, I practice law, and although I practice a different kind of law now, I spent probably 10 years of my career handling litigation over failed software implementation projects. Mm-hmm. And boy, they can be a disaster, and they can be very, very difficult to fix, which I guess we're kind of seeing with healthcare.gov, but hopefully they'll get it working soon. Okay. Well, then my other question.
Yeah, I'll just say on that. It's complex to do. eHealth is, or e-commerce is a science. It really is. I think people don't realize that most of the websites that you work with where you buy things, if they're done right, the people are changing it every week. We're updating and tweaking our website on a weekly basis to refine it and improve it, because the internet always changes and the way people shop always changes. And so there's a very scientific way to do this. And if you're trying to get into it for the first time and you're in a big complex organization, that's a tall order. So I feel for the people in the government that are trying to do it. It's not easy. And then there's a whole back end system to this exchange I don't think a lot of people understand. Something called the Federal Data Hub, where they have to take your Social Security and check your citizenship and check with IRS and find out if you get insurance from an employer. They have to do all these things to connect all these departments, public and private organizations, to determine if you're really eligible for a subsidy, if you're really, who you say you are, and you're not getting somebody else's subsidy, and all this kind of stuff. So there's not just the front end e-commerce piece, which, to your point, we've been doing for a long time. We do really well, but there's also a very complex new form of underwriting. We automated underwriting for a lot of the plans that we sell about 5 or 6 years ago when it was a health issue. So insurance companies gave us their underwriting criteria, and we could, for some people, when they filled out their application, we could approve them on the spot. But this is a new form of underwriting. Right now, it's not about your health; it's about your income and citizenship. So they're building a brand new underwriting engine and then trying to roll that out and plug that into. So it's not easy. It's complex, and there's a lot of new pieces to it. So I definitely feel for them as they try to get this thing up and running.
Yeah. And all of that complexity has got to work whether someone goes through a government exchange or through a private exchange. It's got to work. Right. It's got to work at some level.
Yeah, and oddly enough, they're saying that the data hub, the back end piece, the underwriting piece, is working quite well. So that's apparently it's working in California for the California exchange, and some of these exchanges that are working online, they seem to be enrolling people in subsidized plans. So that part. That harder part, or that new part, seems to be working fairly well.
Okay, and once it's all working, putting aside subsidies for a moment, will the cost of a policy of the same policy, will the cost be the same regardless of whether someone goes to, say, healthcare.gov to buy it versus going to, say, a company like yours, eHealth, to purchase it, or will the prices be different?
No, the prices will be the same. The prices are fixed by law. Health insurance is not like buying an airline ticket or something like that. It's all the plans and all the benefits and all the prices have to be submitted to the Department of Insurance in every state and approved before they're able to be sold. So it's whether you buy it directly from the insurance company, whether you buy it from the exchange, whether you buy it from a broker like us, or the broker down the street, you're going to pay the same price. And people can't offer discounts and they can't offer refunds. So it's a very regulated market. So, where everybody tries to differentiate their business, we try to differentiate on service. We've got, really good quality licensed agents who've worked with us for a long time. They can help you understand the benefits. We do it really quickly online, things like that. So we're a service organization. We can't compete on price. So we have to do a better job for you than the next guy. And then obviously choice. We've got, like I said, we've got more plans than anybody else. And so that kind of thing.
But actually, that was my next question. So eHealth will have more plan options than, say, a government exchange will show consumers?
Well, it'll have different plan options. I mean, once we're set up as a web broker to enroll people with subsidies, if you qualify for a subsidy and decide to shop for a plan using a subsidy, you will see the exact same plans that are on the exchange in your state or that are on healthcare.gov. So it'll be the exact same plans, exact same prices. If you decide to shop without a subsidy, then you will see or if you don't qualify for a subsidy, then you'll be exposed to a wider variety of plans. There are, quote unquote, off exchange plans. So there may be additional options for you. Yeah.
So okay, I hadn't realized that. So if you don't use a subsidy, you'll have more options.
Yeah, because the exchanges, for the most part, limited the number of plans that an insurance company can put in the exchange. And in some cases, major insurers like United Healthcare, I think, is only on the exchange in 4 or 5 states. So some insurers are not participating in the exchange at all, in the government exchanges at all. So they don't have plans that are available by subsidy, but they're still selling plans in the individual market. So there's sort of two markets out there.
So if you don't qualify for a subsidy, it almost sounds like you're better off looking at the private exchanges like eHealth, because you'll see options that you won't see on healthcare.gov or your state exchange.
Yeah, I mean, I don't want to say you're better off. I think you're smart to probably look at both. We'd certainly love that you shop at eHealth. You will see plans there that you don't see on healthcare.gov, but transparency is always a good thing. So I think everybody should really take the time. It's not like buying a book or something online. You really kind of want to look around and see everything that's available.
Right. And once you buy a policy, is the term of that policy under the Affordable Care Act for 1 year?
Yes.
And I take it during that year, like let's say you start off with a bronze plan and 3 months into the year, you think, no, I really want a platinum plan. Can you change mid-year, or do you have to wait until the end of the year to change the plan that you have?
You tip under the short answer is you have to wait. So there's the individual market used to be more, you could come in and out whenever you want. Now you'd have to be medically underwritten, so your application in most states could be declined if you had a pre-existing condition. But there was no sort of time restriction on when you could enroll. Under the Affordable Care Act, there's now a defined open enrollment period that takes place every year. And that's the time when you can come in and add coverage or change your coverage, unless you have what's called a qualifying event. So you lose a job, you lose access to employer-based insurance, or you get a big raise, and so you were in a plan with a subsidy, and now you need to change your subsidy eligibility and stop taking the subsidy so that you're not, taxed at the end of the year. You get married or you have a kid. Any one of those things, any of those sort of life qualifying events, gives you the opportunity to go back and change your coverage. But you can't just sort of decide like, I broke my leg, I better go get a platinum plan instead of a bronze plan. You can't do that. Now, that's sort of under the law, but the law also says that states can create their own open enrollment periods, and insurance companies can create their own open enrollment periods. So, as with everything in this industry, it's just no simple answer, unfortunately. So in your state, there may be a second open enrollment period in the middle of the summer when you could potentially go change your plan, or your insurance company may offer open enrollment periods. There may be, you can apply any time, but there's a 3-month waiting period kind of thing. So it's really going to be still a fair amount of complexity and all over the map. But the thing that you'll know for sure is that you can change your plan every year, once a year during the open enrollment period, and that is guaranteed under the law.
All right. And you mentioned that in some states there might be a 3-month waiting period, and that actually gets to my next question. I've heard a lot of folks say they're not going to get insurance, but they're going to just pay the penalty. And then if they get sick in the middle of the year, they'll go ahead and buy the insurance. Is that, can they do that? Is that a viable option for some folks? Or is there some reason that kind of plan won't work?
That is the whole reason for the mandate in the first place, is to try and prevent people from doing that. But, just to give you an example, if you get in a car accident, and you go to the hospital, and you buy insurance the next day, that insurance is not retroactive. So it's not going to go back and cover your injury. In the same token, I would be hard-pressed to believe that an insurance company or a state insurance commissioner would create a scenario whereby you could get a cancer diagnosis and go out the next day and buy a plan and have that covered. There would have to be a waiting period or some sort of underwriting, or the state may make you go year to year. So I think people who think that, it's a little bit naive. And I hate to make a hard and fast statement like it's not possible under any circumstance, because you just never know how insurance companies are going to, set up their enrollment structure, or how the state's going to set it up. But that doesn't seem like a really viable option to me. Just to give you an example too, I mean, states like New York, before the ACA, or the Obamacare was in place, New York was what was called a guaranteed issue state, where your application could not be declined if you had a pre-existing condition. So sounds great, but very often what happened in New York is that people did just that. They waited until they got sick and then bought insurance. And so the cost of insurance in New York was typically very expensive, and the plans were very, very slim benefits, a lot of co-insurance, maybe hospital-only plans, so no doctor coverage in the plans and things like that. So that's why, they coupled this mandate, this requirement to have health insurance with this guaranteed issue component of the law, is to try and balance that out a little bit.
Okay.
Prevent people from waiting until they get sick to get health insurance.
So it sounds like doing that, even under the new law, it sounds like it's a risky choice for folks.
Yeah, you're going to have a really tough time pulling that off.
Okay. Another thing I've read is that some of the networks of doctors and hospitals that are available under the exchange plans are somewhat limited. I wonder, is there, for folks shopping for health insurance, is there an easy way, whether it's through eHealth or through the federal exchanges, for them to figure out whether their existing doctors and area hospitals are part of the network of the various healthcare options that they can choose from?
Yeah, so we have something called the Physician Finder tool on our website, and if you're shopping for a 2013 plan, so it's a plan that doesn't have all the ACA benefits, which in some states you can still enroll in those and keep them until next year. Our Physician Finder tool is up and running, and it should work, so you can do a comparison that way. With the new plans, we're still loading all that data into the tool, and it's just taken a long time. You have to understand that throughout the history of the company, we update plans and benefits all the time. We update the Physician Finder tool on a regular basis, but it's never been the case that we got brand new plans for every insurance company and every provider network nationwide, basically all at once.
Yeah, I'm sure it's a challenge.
So it's a challenge. So I think we're about, we're very close to having every plan available on the site. I don't know if we're quite there yet. But then getting the provider tool updated is also, a work in progress. So I know that some of the exchanges have those and some don't. I know that at least the California tool was broken for a while. I don't know if it's still broken. So yeah, that's one of those things where I would definitely, again, encourage people to pick up the phone and call. You might want to call your doctor as well. Their office might know. Our agents will have access to that data for some plans, and for some plans they might not yet. So that's a real challenge right now.
Okay.
I don't know that there's a really good solution out there.
All right. Well, eventually,
there may be. I just don't know. That's one where I'm not confident that there's a one-stop shop for that at this point.
All right. Well, I'll leave a link to the Physician Finder tool in the show notes, and that can at least be a starting point for folks. And as you said, they can always call either their doctors or the insurance companies or exchanges that they're considering, purchasing from.
Yeah, you can go to doctor.ehealthinsurance.com too, and you can search through a provider network there. I'd venture to say that some of the stuff will be up to date and some of it will not be for the 2014 plan. So it's a good idea to double check.
Okay. That's doctor.ehealthinsurance.com.
Yeah.
Okay. And then real quick, it's sort of at a high level. I mean, maybe this is a difficult question to answer, but when you listen to the politicians, some will tell you the costs are just going sky high on insurance. Some say, no, it's going down. I assume, I'm guessing that for some folks, they'll pay more than they would have before the new law, and some will, I guess, pay less, I would think. But do you have any sort of general sense for us as to whether under the new law, policies will generally be going up or down or staying the same?
Well, if we take subsidies out of the equation, we don't factor in the subsidies. Prices appear to be going up, and that's it's pretty definitive that the premiums are higher. And now that's partially in response or because they just cover more benefits, right? I mean, you can't add things like maternity coverage and dental and all these things to new plans and not expect, you can't offer more coverage not expect the cost to go up. It's just there's no sort of free lunch on that. What we have found is that when you look at as we spoke about before, the pre-ACA plans was more sort of a la carte, right? You could mix and match benefits and pick and choose the things that you wanted. They moved to this model where we're going to sort of share the costs more broadly, and everybody's going to have to get benefits even if they don't want them. And we can argue whether or not that's a good idea, but when you do that, it raises the cost. And so we do something every year called a cost and benefit report, where we say this is what people are buying in the marketplace, in our marketplace. We look at about 500,000 policies that we have in effect. We look at the cost, the benefits, deductibles, things like that. And, last year, the average plan was around $190 a month. I have to pull it up and look at it exactly, but it was under $200. And now that's not a plan that's going to cover all the benefits that are covered by these new plans. So this year we updated that report and we looked at more comprehensive benefits. So we did a subset of that data and we said, okay, how much do plans cost when they cover when they have comparable benefits to what's going to be available next year? And when we did that, the plans were around $220, $240. So $40, $50 higher, still a little bit less than the starting price of a plan in the marketplace today for somebody who's an adult who's 21 years old. But as you get older, the cost of the plans definitely goes up. So, and it's younger people who were buying in the old market were paying oftentimes less than $100 or around $120 a month. The cheapest plan I've seen for that age group is around $200. So they are costing more, but you are getting a higher benefit level.
Okay. And I take it you made a reference to age, and I don't know why this didn't occur to me until recently, but your age is one of the factors that insurance companies consider in pricing the insurance.
Yes, in fact, in a lot of states, it's the only factor. Now, the law gave states the option to add tobacco use as another underwriting factor, but a lot of states have decided not to do that. So it's sort of a 3-to-1 ratio. So if the cheapest plan that they can offer you at say 21 is $200 a month, then the most expensive plan is $600 a month, and that's sort of how they build it up. So all these. The government actually put out what they call a data book, and it showed premiums for plans in all 50 states or all 36 states where the federal government's doing an exchange, and you can actually filter it by age, and you can see how the premiums increase as you age.
And where's that resource available?
I'll send it to you.
Okay, good.
If I tried to read you the URL, it's one of those like XYP
right.
kind of things.
Yeah. Send that to me if you would, and I'll include it in the show notes. I think that'll be helpful.
It's fun to play around with too. It's sort of interesting just to look at. If you're a healthcare, geek like me, it's fun to play around with.
Right. Okay. One last question, and I appreciate your time. I know with all the new announcements and everything going on, you're working night and day. But if you could just kind of give us at a high level how the subsidies work, kind of a rough idea of who qualifies for a subsidy, and then kind of related to that, if you have any tools, perhaps on eHealth or other sites you're aware of, more people could input their information and kind of get a better sense as to whether they'll qualify for a subsidy.
Yeah, so it's a great question. It's sort of the $1,000 question for people, and it's really complicated. I will tell you that we did a book on this and we did a video on this, and if you go to eHealth.com/Affordable Care Act, you can find the book there, and we sort of break it down step by step. But let me try to give you an idea of how it works. You may qualify for a subsidy under the Affordable Care Act if your income is below 400% of the federal poverty level and above 133% of the federal poverty level. So the federal, for a person, a single household, the federal poverty level starts at around $15,000 a year and goes up to about $46,000 a year in modified adjusted gross income. So after you factor out, deductions and things like that. If you go to a two-person household, it's income up to about $62,000 a year. Three-person household, $78,000 a year. So you get it. So the more kids you have, you get married, things like that, your income as a percentage of the federal poverty level goes up. So you have to be a U.S. citizen. You can't be in jail. You have to be living in the U.S. And you can't have access to affordable coverage from an employer. So if your income qualifies, you're a resident, you're not in jail, and you don't have access to employer-based insurance, then you may qualify for a subsidy, but you don't necessarily get one. And this is where it gets really complicated. So let's say you meet all that criteria. You're 25 years old, you make $40,000 a year, you're a citizen, you live in the U.S., you're not in jail, and your employer doesn't offer you health insurance. You go into the exchange. Now what determines your eligibility for a subsidy is the price of the second least expensive silver plan in the marketplace where you live. So remember we talked about actuarial value. There's bronze, silver, gold, and platinum.
Right.
The silver plan covers 70% of your costs. So the second least expensive silver plan in your market is what the government what we call the benchmark plan. So that plan sets the benchmark for your subsidy. If that plan costs more than if you make $40,000 a year and that plan costs more than 9.5% of your taxable income, then you qualify for a subsidy, and your subsidy is whatever the value of that plan is over 9.5% of your income. So,
this sounds very easy to follow, Nate.
I try to explain it to people, and I see their eyes gloss over.
I'm sure a bunch of lawyers wrote this one.
Yeah, it's tough to understand, and the limit. So basically, the subsidy is really a limit on your premium. So if you qualify for a subsidy, think of the subsidy as a cap. It basically says there's a threshold that you will hit if you want to buy that silver plan, and once you hit that threshold, you pay no more. We'll cover the costs above that. And then whatever the cost above that is, so I'll just give you a real life example. At 400% of the federal poverty level, if your income is right at the tippy top, you're making about $3,800 a year, or $3,800 a month. The cap on your premium is $364 a month. So if that benchmark plan were to cost $400 a month, your subsidy would be $400 minus $364, which would be $36. So you qualify for $36, and you can for a $36 subsidy, and you can take that subsidy and go buy a cheaper bronze plan or a cheaper silver plan. You can take it and buy a more expensive platinum plan. So that's sort of in a nutshell how it works. And then as your income goes down, the cap on what you're going to spend out of pocket for the plan goes down. So at 200% of the federal poverty level, you can't spend more than 6.3% of your income on that benchmark plan. And so your amount of the subsidy goes up, and then again you can take that same dollar amount and go shop for any plan you want.
Okay.
So it's not terribly easy to understand. That's why the video and the book break it out with pictures and animation. It's a lot easier if you see it.
Well, here's what I'll do, Nate. I'll leave a link to that in the show notes so folks can find it.
Okay.
I also will leave a link to an article I wrote not long ago that embedded the Kaiser Foundation calculator. Are you familiar with their calculator?
I am, yes.
Do you think
we created our own that's very similar. In fact, Consumer Reports just did a report testing ours and several others, and found essentially that we all provide the same information. So
okay, well, can you send me a link to that as well?
Yeah, absolutely.
All right, and I'll include that. That's great. And at the end of the day, I guess those calculators can give folks at least a rough idea, but ultimately they'll find out when they apply for the insurance through the federal exchanges or sites like eHealth once you have the ability to offer the subsidies.
Well, yeah, I mean, it's very clear in the law that the only place that can really determine your subsidy is the federal data hub. So all roads sort of lead back to that data hub. So everybody else is just sort of making an estimate, and it really depends on the information that you put in and things like that.
Yeah. Now, eventually, though, private exchanges like eHealth will have access to that, or will be able to route people through the data hub. In other words, eventually folks can go to either healthcare.gov if they want, or their state exchange, or a site like eHealth, and still find out what they qualify for on subsidies. That'll eventually be the case.
What we've done is, because we expected to be able to enroll people the way you talked about it, but it's because of the delays. What we've done is create something called our rain check system. So you can go to our website and you can say, I want to look at 2014 plans and I want to estimate my subsidy. And you go to our subsidy calculator tool and you put in your income and you put in some basic demographic information, and then we'll estimate your subsidy and show you all the plans available that we can sell today. We can't sell them with a subsidy, but these are the plans we could sell if you didn't qualify for a subsidy. So we'll show you those same plans with your subsidized price, your price after subsidy. And then if you find something you like, you can sort of save it, and we'll get back to you when we can enroll you. So that's what we've done, and the way that we will roll this out eventually when we actually can enroll you will be very similar. So rather than having to go and fill out all this complex stuff to find out what your subsidy is first, we'll give you the same sort of shopping experience you have now. You come in, you estimate what your subsidy is going to be using our calculator, then you go into the marketplace, and ours is really quick and simple. It's like 3 or 4 pieces of data. Then you go into the marketplace and you see the estimated subsidized price. You shop around, you find the plan that you like, and then when you're ready to apply, then you go over and fill out the real application, and then come back and you see the actual price. So once you've gone through, and that's a fairly lengthy process. They say 30 to 45 minutes. It could take longer. You've got to tax information and things like that. But once you get, and then you'll get the real subsidy amount. And then you can confirm, okay, if my subsidy is more, I might want to get a more expensive plan, or my subsidy is less, I might want to get something else. And then you go ahead and apply, and that's the way it'll go. So even once this is fully implemented, you won't have to go through that really complex application form before you can shop for plans. We'll still have this sort of pre-subsidy calculation shopping experience.
Okay.
For people to go through.
And one last question on the subsidies, as I've heard that, one of the challenges is for some folks is that they don't know how much they're going to make in 2014. Either they have variable compensation, or, they may end up getting a job in the middle of the year that pays more, or losing a job. And it's my understanding they can choose between whether they get the subsidy monthly, as I guess a reduction in their premium, or they hold off and wait until the end of the year, in this case, the end of 2014, when they know their income for sure, and then get this whatever subsidy they're entitled to, I guess, is some sort of tax refund at the end of the year. Is that right? They have sort of the monthly, or they wait till the end of the year option for collecting the subsidy?
Yeah, now you still have to go through the same application process, and then at least the early implementation of this that I saw when we were testing it on the front end was that you could determine how much of your subsidy you wanted to apply to your plan every month versus how much you wanted to collect at the end of the year, how much you wanted to defer. So there was a tool that we sort of spec'd out where you could say, we come back and say, your subsidy is $50 a month. Do you want to use the whole thing now, or do you want to defer some of it? So you could say, I only want to use $25 now, and the rest of it I'll get at the end of the year. So to answer your question, yes, that's correct. And exactly how that's going to work, I don't know all the complex details, but yeah, my understanding is you can defer some of it or potentially all of it to the end of the year.
Okay. Well, listen, Nate, I appreciate your patience. I know I've been pummeling you with questions. It's just that this is, as you know, it's so complicated. And for folks that aren't, living and breathing this day in and day out like you are, it's kind of hard to wrap our minds around. Is there anything we should know that I know we've been through a lot in the last hour or so, but, is there any questions I didn't ask you, or things that, you think we ought to know? Issues that you see folks running into as they try to work through the application process? Or
boy, I have enjoyed this so much because usually when I start to talk about this, people like walk out of the room, including my wife. So it's nice to talk about it and somebody actually listens.
Well, I'm listening. I don't know. Everyone else may have turned us off. It may be just you and me, but.
Right. Well, that's fine. I'll call you at home sometime and just bore you that way. I think, you asked some great questions, and we did sort of go through the list of stuff you wanted to talk about ahead of time. I would just say that, people should be really proactive. If you have questions, ask, find a resource, a good, knowledgeable resource that can help you. We may not love the Affordable Care Act. I know some people are very upset about it. Some people are thrilled about it. Regardless of how you feel about it, it is the law of the land, and to the point about people waiting, and just paying the tax penalty, you really got to think that through, because it is not the case that you can just get insurance anytime you feel like it. And I guess those would be my parting words of wisdom.
All right, Nate. Well, listen, I really appreciate it. Thank you so much for coming on the show.
Okay, thank you. Good to talk to you.
You too. Take care.
All right, bye-bye.
Well, I hope you found the interview with Nate helpful and informative. I know that the new healthcare law is pretty complicated, and the problems with the rollout haven't helped. But hopefully, Nate was able to answer your questions. Remember, you can check out his company's website. The easiest way is just to go to DoughRoller.net/eHealth, and that'll redirect you to a page where on eHealth's website where you can get a quote on insurance very quickly. And as always, be sure to compare that with other policies that you'll find on your exchanges and whatnot. But it's a good way to get an idea of what the insurance will cost you. And if we didn't cover a topic or Nate didn't answer a question that you may have, feel free to send me an email. You can reach me at dr@DoughRoller.net. I'll do my best to answer your question, and if I can't, I'm happy to pass it on to Nate to get his response. Happy to do that. And with that, it brings our show to a close. As always, you can find the show notes to this episode. This is episode 4 at DoughRoller.net/podcast 4. I'll have links to all of the resources Nate mentioned in today's interview. Also, you can subscribe to this podcast and leave a review of this podcast on the iTunes page. The easiest way to find it is just to go to DoughRoller.net/iTunes. That'll direct you to the iTunes page where the show resides. I appreciate your reviews. They're very helpful to me. I read all of them. Helps me improve the show. And finally, if you're not already a subscriber to the DoughRoller newsletter, you can do that at DoughRoller.net/newsletter. It's a free weekly newsletter that goes out every Saturday at 8 p.m. We pack it full of resources and tips to help you make the most of your finances. So that brings our show to a close. Until next time, remember, the best thing money can buy is financial freedom.